Thank you all for joining us today. This is our first in a series of 8 webinars with Jonathan Pattenberg from Stroudwater Associates. If you recall, last fall we did a survey where hospital CEOs and CFOs were asked to rank topics that you felt were most beneficial to you. And so we took your responses and made a series out of those. So as usual, we want to hear from you guys. If you have questions as you go along, everyone has controls over your mute and unmute. But if you'd like to put something in the chat, I'll be manning the chat and watching that. So if you guys have any questions at all, please feel free to blurt them out, or we'll go over questions at the end as well. So thank you for your time. We are recording this and we will be getting it on our YouTube channel shortly. So thank you guys. And Jonathan, I'll turn it over to you.
Thanks, Laura. So excited to kick off this year's webinar series. And again, as Laura had mentioned, this presentation is being recorded. And what we will also do is after this presentation is over, I will send over a PDF copy of the slide deck to Laura. And then I'm sure that will be sent out to all of the participants on the webinar today. Now, when we talk through the topics, again, the webinar series is based on the specific topics that were solicited from the different people on the survey. And the goal is to provide additional information and really that operational information to allow organizations to either improve efficiencies, to improve their financial performance, improve outcomes, any of those different topics. Now, the webinar today is really laying the foundation for the 8-part webinar series. And today we're going to go over a lot of different information and different topics. And the goal is really to raise questions in areas that we as organizations can focus on if really that goal to improve our performance going forward. As Laura mentioned, also, if you do have questions, please do not hesitate to submit them in the chat box. I do want to make sure that we're able to answer and address any questions that you may have. Now, when we're going through the presentation today also, just one thing I wanted to emphasize. There were probably close to 100 different bullets or opportunities in this report. Now, as we go through, I am not going to go over every single one. What I'm going to do is talk through the different information on different hot topics that are popping up in today's environment. But again, this document can also serve as a leave behind where you can take the information out of this document and really do a self-diagnostic check for your organization. And again, the information in this document is really pulling upon the best practices that we've seen across organizations across the country. And again, the goal, to summarize one more time, is really just to improve performance going forward. Now, the topics that we're going to focus on is specifically focused today towards critical access hospitals. And the reason why I mentioned that is because operating as a critical access hospital, some of the approaches and the direction towards business varies than when compared to either even a sole community hospital or another designation type. So the approach to business at the highest level is similar, but when you get into some of those nuances at that business level, it's important to differentiate some of those different opportunities to ensure that we are creating an environment that works for that critical access hospital. Again, under the realization that many of you are your emergent care provider, or really that safety net provider for a region. Now, when we talk about the economic philosophy of critical access hospitals, one thing that we often see that is a real opportunity for organizations is to really start to break down the siloing between either clinical and finance or administrative and non-administrative. And one of the biggest opportunities is to expand awareness and education around financial performance and financial outcomes. I can't tell you how many times we've gone into hospitals where the clinical side is operated almost as a separate business or distinct entity from the finance side. And there are really not those linkages that cross between both sides. And what we've come to realize is there is a direct linkage between the clinical outcomes and clinical performance and the financial position of an organization. So what we need to start to do is to realize and work with the different departments throughout our hospital to get them to realize that each one of those departments plays a viable role in the organization as a whole. And each individual department is really a mini business unit that becomes a part of that broader organization as a whole. And we really need to start looking at things more from a contribution margin perspective and using that to leverage the collective power of the organization as a whole to ensure that you can continue to provide those services going forward. Again, as a critical access hospital, not every service is going to make a margin from a direct revenue to expense perspective. And oftentimes we need to view it from that contribution margin perspective. Again, the goal is for the company as a whole to make a profit, not necessarily for every individual department. And realizing that in many instances, we have to dedicate mission dollars to support certain programs. But again, without that program or that service being offered, it could put patients in an adverse position or in an unsafe position relative to healthcare delivery. So again, understanding also from the perspective of critical access hospitals, when we think about expenses in a critical access hospital, oftentimes you cannot cut your way to success from an expense perspective. Now, again, you can obviously be more efficient. You can worry about controlling expenses and looking at those different factors. But eventually you're going to get to a point where you run up to those minimum staffing standards. And again, if we take med-surg, for instance, whether you have one patient or 5 patients on a floor, let's say, you still need at least one nurse. So again, it's not like if your average daily census drops down to a 2, you could say, oh, well, we don't need nurses anymore because we don't have that many patients. So again, taking it from that perspective, looking forward, is really how we can start to fundamentally change our organizations. Now, the first area that we're going to focus on today is around provider complement. And that's everything from primary care to specialty to behavioral health to all of those different services. Now, one of the biggest opportunities I would say for organizations is really to start to catalog the providers within your service area. Now, oftentimes we will go into a rural community and we'll ask the hospital, hey, do you have a catalog of your providers? And they'll only provide or they'll only keep track of the providers that are either employed by that organization or those that they have a direct relationship with. Now, when we're looking at additional efforts or expansion opportunities or all of those different factors, we need to base that on the providers within the service area, not necessarily the providers that are employed by our organization. Now, if we are looking at expanding and adding a primary care provider or a specialty provider, if there is a surplus of providers throughout the region, just because they are not employed directly by our organization does not mean that we need to add, again, those additional providers. I've seen many times where organizations have taken the if you build it, they will come type approach and assume that they should just hire or bring on any provider that they can get because the ability to bring on a provider will lead to increased revenue. And again, as we've started to see the expansion of telehealth and the expansion of services and outreach efforts, more now than ever, we really need to ensure that we are effectively evaluating the number of providers within a service area to ensure that, again, we do not create an environment where there is an excess of providers, especially when we look at different opportunities like the NCQA, the tuition reimbursement opportunities, or the loan forgiveness, or the ability to get the increase in the fee schedules, or rural health clinic opportunities. Again, all of those different things is dependent upon the number of providers and the certain scores for a region. So take all of that stuff into account. Now, many of you have realized, I know many of you on this webinar have rural health clinics, but many of you realize that as a part of the Consolidated Appropriations Act of 2021, there was a material change to the rural health clinic reimbursement methodology. And they got away with, or they've gone away with, how the rural health clinics that are aligned under hospitals with fewer than 50 beds, including our critical access hospitals, are reimbursed. Gone are the days of full cost-based reimbursement. And going forward, we need to evaluate the services from a cost-based perspective and compare that to the Medicare Economic Index increase each year to ensure that we are staffing and providing those services in a financially advantageous way. Now, again, In the past, before the change of that RHC reimbursement methodology, I'd say 80 to 90% of the time, aligning a clinic under a critical access hospital as a rural health clinic was the most advantageous reimbursement designation. Going forward, I would say it's probably closer to a 50-50 split now. And no more can we just assume that a rural health clinic is the most advantageous designation. We need to evaluate going forward provider-based clinics. Again, if we can meet the distance requirements as a critical access hospital, is the ability to convert to a provider-based clinic. We must continue to evaluate the alignment and designation of those practices and where we are placing our providers to ensure that we are receiving adequate reimbursements. Again, I don't think there's anybody on this webinar that could say that their revenue is going up at a greater rate than their expenses. And in an environment like that, we have to continue to evaluate and put ourselves in the position to be successful going forward. Also, with the advent and the expansion of telehealth services, is there the ability to add telehealth specialty providers to our community? If we are operating in a remote region with an emergency room, can we add on telecardiac or different type of services from that perspective to ensure patients can get services at the community, but also potentially reduce the number of transfers out of our facility because maybe we're not able to get those specialty services and we have to refer elsewhere or transfer elsewhere. One of the things I would also say from a perspective of provider complement is to leverage available information out there. Again, we need to continue to benchmark the MGMA to ensure that we are paying our providers within a reasonable range. We were at a critical access hospital up in Montana one time, and they were paying one of their primary care physicians like $600,000 a year for the services relative to primary care. And again, what they weren't doing is they weren't breaking down the actual services that that provider was doing. That provider was working in the emergency room. They were providing hospitalist coverage. They were working in the clinic. They were also the medical director. Where they ran into issues was they did not differentiate and look at their provider contracts to break down all those different factors. Now, I'm not saying that $600,000 is by any means reasonable, but where they first got into trouble was not for differentiating the different types of services that they were providing for that organization. And had they broken down the compensation that that provider was receiving for each of those different functional areas, they may have been able to meet the requirements relative to the fair market assessment perspective. Now, what we also want to do is organizations, and we've seen an increase in the fines coming out from CMS and the different entities at the federal level. Again, doing those fair market assessments for our providers. It's not something that we can continue to say, oh, because we're in rural and we don't have access and we're really busy, or we're not going to get audited, we don't need to do those fair market assessments. We have to make sure that we continue to do those fair market assessments and conduct the regular START analysis. Now, even if your organization does not participate, if we're going to talk about performance improvement for our providers, even if our organization does not participate in a joint commission or some other deeming type approach, we can still borrow upon the principles of those organizations to improve the performance of our providers and our staff. And an example of that is the OPPE and FPPE coming out of Joint Commission that really looks at the evaluation of our providers to ensure that they are continuing to provide services of a high standard necessary to maintain their privileges at your hospital. Now, also taking that to a different perspective relative to culture, whether you borrow upon the Studer principles or somebody else, again, leverage opportunities and leverage those means that fit within your organizational structure and use them as a way to improve outcomes and improve things from that perspective. Again, even if you don't officially participate or sign up with one of those organizations, the ability to move the needle, particularly with our providers, will go a long way towards improving the outcomes for our patient population. Now, the last area really around the provider complement is we as organizations in the healthcare industry as a whole has continued to move more towards either population-based outcomes, ACOs, capitation, any way that you want to evaluate it from that perspective. We as organizations really need to start to build in those type of population-based outcomes into our clinical delivery care models. Now, in our clinics as a whole, whether or not we participate in the PCMH model or we implement certain contracts with the commercial payers to try to get some type of PMPM, all of those are additional opportunities that we should explore. In addition to that, especially because Medicare has started to open the doors for your TCM, your transitional care management, your chronic care management, your behavioral health interventions, your COCM, all of those different factors. Again, leverage all of those opportunities to expand the access for your patients, to increase the number of touch points that you have with your patients, but also in today's environment, it'll increase the revenue that you receive as an organization. So really from a provider perspective, really go as far to say, how can we change? How can we continue to move things forward? One last thing on the provider side also really deals with provider compensation. Again, gone are the days where we only give our providers a fixed salary per contract. And what we need to do is in today's times, we really need to incorporate and include additional factors for the reimbursement or the salaries of our providers. Going forward, we need to look at adding in quality scores, patient panel sizes, work RVUs, all of those different things to create a multi-pronged approach to how we are going to reimburse our providers or compensate our providers to put us in an environment where we can be successful in today's times in a fee-for-service model with how we're reimbursing our providers, but also ensuring that we are setting ourselves up to be successful down the road where patient panel sizes and quality scores and all of those different things will also be of increasing importance. Again, start to make the transitional changes now and do not lock yourself into one environment that puts you in a disadvantageous position down the road. The next area we're going to focus on is inpatient services. And for purposes of today, we're really going to focus on your acute services, your swing bed services, and observation. Again, I don't really want to get into ICU, distinct units, and all of those different factors. There's countless things we could talk about just with those three service areas. Now, when we talk about our services from an acute perspective, we as an organization really need to target the amount of patients that are coming out of our emergency room. And when we look at that perspective, we should set a target. Again, not to say that we're going to achieve this, but we should be setting a target that 10% of our ED volume should lead to some type of admission. Now, this can be used a couple different ways to evaluate not only the inpatient services, but it can also be used to evaluate the services that we're providing in our emergency room as a whole. Now, if we are not hitting that 10% admission rate relative to ED volume, and what I mean by that is if you have 1,000 ED patients, you should have 100 admissions. So from that perspective, so going forward, looking at those different factors, again, the first part that we can evaluate from that perspective is if we are hitting that 10% threshold, it could mean that there is an over-reliance on your emergency department for non-emergent services. So what we can evaluate from that perspective is, do we have too many 99281s, 2s and 3s, and not enough of the 4s and 5s? Again, if we have an over-reliance on our emergency room for non-emergent services, we will not be able to achieve that 10% threshold. The other area from that perspective also is if we're unable to achieve that 10% threshold, but we do have a higher acuity level for our emergency room patients, then we may have too many transfers leaving our facility. Maybe it's the easiest path of resistance for our providers in the emergency room to transfer patients to another facility than to admit patients into their own facility. Again, we've seen this countless times across the country. So use that 10% threshold as a means to dictate and determine and also to evaluate not only the services from a staffing perspective relative to your inpatient unit, but also the performance of your emergency department relative to whether or not you are admitting enough patients. Another thing we want to do as an opportunity, and this really comes from a swing bed perspective or a post-acute care, we want to constantly reach out to organizations when we transfer patients to other facilities to continue to track those patients and see if we have an opportunity to get those patients back into our facility for post-acute care services. Oftentimes, we will see a patient is sent to a large tertiary facility, and then upon discharge, that patient is sent to some type of SNF or some rehab facility that's not within the community of that patient. And again, oftentimes it's because those organizations are failing to track and follow up on those patients for potential post-acute care services. This, I would say, is a big opportunity for organizations going forward. Now, when we look at the totality of services that you provide within your facility, one of the biggest areas I would say is really around the care spectrum. Now, the care spectrum is the delineation of services that you can provide within your facility across several different areas. Again, medical staff, nursing, pharmacy, medical equipment, and so forth. Now, when you're looking at your care spectrum, you're not only defining the services that you can provide, but you're also identifying potential gaps and barriers to accepting additional patients down the road. So this can really be a two-pronged approach. One, you can use the care spectrum to say, what are the services that we can provide? And then leveraging that information to reach out to larger organizations to say, these are the type of patients we can care for. And again, the care spectrum is something that can be used in the emergency room for determining transfers. It can be used for acute admissions. It can also be used for determining swing bed admissions. So again, across all of those different areas. Now, when you look at from the perspective of either education or expansion or acquisition of equipment, defining that care spectrum again will identify those barriers. Now, say for instance, you are able to do everything relative to wound care, but maybe you don't have a wound vac. That's the only thing preventing you from taking post-acute care services or patients that need wound care type services. Now, this would allow you to actually identify and do some type of cost projection to say, wait a minute, the only thing preventing us from taking wound care patients is a wound vac. Well, how much would it cost to acquire a wound vac? If we had a wound vac, how many more patients would we be able to receive? So it allows you to break down, again, those barriers or expansion of competencies for certain staff, again, with the wound care perspective. Maybe you have 2 nurses that are able to do all the wound care services, but they're not able to provide the 24/7 coverage. So it would allow you to identify and train additional staff so that you can provide that service. Again, the goal is to expand that spectrum as much as possible. Also, when we look at swing bed services, now I know that this is kind of a taboo description or title. It's really around active solicitation. Now, the reason why I say active solicitation as opposed to patient recruitment or different factors is it's identifying an approach that we must take to go after specifically post-acute care type patients. Now, the opposite of active is passive. And what I would say is many organizations take a passive approach to post-acute care type services. And what I mean by passive is instead of them actively reaching out and engaging larger facilities to try to get patients, they are waiting for referrals to come to them. Now, in an active solicitation approach, you must reach out constantly to try to solicit or pursue patients to come to your facility for those post-acute care services. Now, the last hospital I was a CFO at, our chief nursing officer did a great job of taking a proactive approach to getting patients. And every single day, they would be reaching out to those large tertiary facilities saying, I have X number of beds available. I can take these number of patients, and really going after patients that fit within that spectrum of services that you could provide. Again, reach out, engage those other organizations for patients to come to your facility. Do not wait for just referrals to be sent to your facility. And the reason why I say that is if you're waiting solely for referrals to be sent to your facility, if you're a case manager or a discharge planner at a large hospital and you come in today and you need to place 30 patients, are you going to call a critical access hospital, maybe have 5 to 10 beds available? Or are you going to call a 200 bed SNF that maybe could have 50 beds available? Again, they're trying to move as many patients as possible. So they're going to call the organizations first that are able to take the most number of patients. And unfortunately, what ends up happening is in this environment, because those easy to place patients are obviously going quickly, the patients that are getting referred to either the critical access hospitals or the smaller facilities are those patients with no Medicare days left or multiple comorbidities or just difficult to place patients. So again, taking that active role will allow you to go after specific patients that fit more within the clinical services that you're capable and equipped to provide instead of getting referrals that are maybe difficult to place patients. Now, from a swing bed perspective, we generally like to say you should be targeting an average daily census of 4 per 10,000 people in your service area. So again, if you have 10,000 people in your service area, you should have 4. If it's 20,000, you should have 8, and so forth. Now, again, this is also used as a gauge because we are limited as 25-bed critical access hospitals. If we're in a service area with 30,000 people and our average daily census on the acute side is 20, we're not going to be able to achieve a swing bed census of 4 per 10,000. But again, when we look across most critical access hospitals across the country, they do have the available beds and they do have the ability to achieve that 4 per 10,000. So again, take an active role in reaching out to organizations in an effort to increase volumes and increase patients being sent to your facility. Now, I can't talk about the ability of growing all these volumes without at least focusing a little bit on the financial factors relative to critical access hospitals. Now, from a post-acute care perspective, it's very important to monitor your Medicaid NF rate, the Medicaid nursing facility carve-out rate. And I've seen these rates range anywhere on average from $175 up to about $275. Now, the way it works on the Medicare cost report is only the Medicare and Medicare Advantage days goes into determining your cost-based routine daily rate. All other days that you put into one of those swing beds is carved out at that Medicaid nursing facility rate. So what I mean by this is say your Medicaid nursing facility rate is $200 per visit, and you're able to negotiate a $400 daily rate to take commercial swing bed patients. This will actually turn you a net profit because Medicare is only going to ding you the $200 per visit relative to the cost when determining your rate, but you're getting $400 from commercial. So again, what we want to do is we want to evaluate and monitor this rate. And we want to use that as a way to negotiate with commercial payers or different payers for these services that could be received in a post-acute care setting. Oftentimes, we will talk to a CFO or somebody in a swing bed program, and they'll say, our daily rate is $2,000. I can't get $2,000 from a commercial patient. We're losing money by every commercial patient we take. And that's not the way the Medicare cost report works. So again, leverage this opportunity. I know of a hospital on the East Coast that actually engaged a commercial payer. And what they did is they negotiated a $1,000 daily rate for drug treatment type services. And what they did is their carve out rate was only, I think, $250 a day, but they were getting $1,000 per day for those services. Now, again, they were making $750 profit relative to the cost-based impact. So this is a way that we can leverage post-acute care services and leverage an expansion to non-Medicare type business in a swing bed or post-acute care setting in a way that does not impact us as an organization. For those of you that are in a system relationship, I've also seen systems leverage this as a way to free up beds also so that they can take uh, additional DRGs instead of diverting or transferring patients elsewhere. The last area also around both the admission process is when we look at other facilities around post-acute care services, and we look at our SNFs, pretty much our non-critical access hospitals, they're able to make a yes or no decision whether or not they're going to accept a patient, usually in less than 2 hours. On average, our critical access hospitals take anywhere from 4 hours to 2 days on average to make a yes or no decision whether or not they are going to accept a post acute care patient. Now, what I can tell you is if a post acute care facility, whether it's a SNF, a rehab facility, or whatever else it may be, if they're able to make a yes or no decision in 2 hours, but it's taking your organization, let's just say 6 hours, that patient will most likely be placed at that other facility before you can either make a yes or no decision. So again, we as organizations need to expedite the process and make a yes or no decision quicker relative to the post acute care services, or we will always continue to get those hard to place patients going forward. Now, when we talk about the inpatient admission services, also, what we also want to do from an acute perspective, the insurance companies are getting harder to place patients or getting harder to get those prior authorizations or anything relative to an inpatient admission. We as organizations, again, need to leverage things like Milliman or Interqual or other types of programs to be able to evaluate whether or not certain patients meet the care requirements to qualify for an inpatient admission or whether or not they should be of an observation status. Again, focus on those different factors, leverage technology, and continue to put yourself in an environment to ensure that you're meeting those different requirements. Now, upon discharge and when your patients are actually in the facility, we need to continue to improve the quality of services that we are providing for our patients. So again, implement things like hourly rounding, bedside handoffs, all of those different things to ensure the patients are getting and a part of the delivery care process. Gone are the days we can't continue to provide care from a distance. We need to start to engage our patients relative to their care, the outcomes, and all of those different factors. What we also want to do is we want to ensure, if possible, one of the biggest opportunities is to have our pharmacist upon discharge meet with patients, discuss their medications, answer any questions they have. Again, all of those different factors plays a role into whether or not a patient feels like they were adequately served and cared for while they were receiving those services at your facility. Now, the last area around the inpatient side is really around the nurse to patient ratios. Now, some states have gone in and solidified in either state law or guidance, administrative rules, whatever it may be, certain nurse to patient ratios. Now, probably the most common example is California. They've published theirs for acute services. It's 5-to-1, ICU it's 3-to-1, SNF level services is 8-to-1, and so forth. Even if you don't have something within your particular state, look nationally to see what the standards are. Again, not necessarily saying that you can definitely operate at that level, but implementing something will allow you to create an environment where you can manage staff and expenses to those different levels. And if you're unable to achieve those certain levels, it could mean competency concerns, it could be acuity of patients, it could be a whole different factor. But again, linking to and evaluating to those different ratios will allow you to, again, create an environment where you can look to improve from that perspective going forward. Next area that we're going to talk about is emergency services. Now, this is difficult many times in rural communities. Oftentimes, there are not urgent care centers, there's not after hour care centers. But within critical access hospitals, because of the cost based nature of the services that we provide, we really need to evaluate the patient distribution and the services they were receiving within our facility. And what happens, particularly in rural communities, is there's often an over reliance on the emergency room for non emergent care. Maybe a patient couldn't get into their primary care provider, so they went to the emergency room. Or maybe it was after hours, and again, there's no urgent care in your community, so they decided to go to the emergency room. Different commercial payers and different entities are starting to deny claims within an emergency room for non emergent care. So, what we need to do as organizations is continue to evaluate the services that we're providing, the patients that are coming into our facilities to receive care. And what we need to evaluate is we need to create an environment there. Maybe we need to average or extend after hour clinics or partially open on the weekends for certain services. Again, because the emergency room is one of the most costly areas within the hospital, you have physician coverage, and not just physician coverage, but expensive provider coverage. We have higher number of nurses. Again, all of those different factors goes into establishing the cost structure of that emergency room. And what we don't want to do is we don't want to create an environment where that emergency room remains both for emergency care services, but also as a means for primary care services. Evaluate the distribution of services within the emergency room. And if you have a number of patients near a certain number of hours that are leveraging that for primary care type services, evaluate if you could expand primary care within your community, potentially add an APP, potentially extend hours, all of those different factors. What we also want to do is within our emergency room is we want to engage the other facilities that we have transfer relationships with. Now, one thing the COVID pandemic has shown is that many organizations have been tapped and stretched relative to the ability to provide services. What we want to do is we want to continue to engage the organizations that we send our patients to from a transfer perspective and see what we could do to potentially expand access to care or the ability to provide care within our own facility. Now, because many of those larger organizations have also been hit with staff shortages and providers leaving and all of those different factors, in today's environment, we may have the ability to work with them through telehealth means or different factors to keep patients local versus actually sending them to those larger facilities. Again, leverage all of those different opportunities as a way to expand the reliance on your hospital as a whole. This is something that will continue to benefit you down the road. There's no organization that would be worse off by expanding their care competencies and the ability to provide patients within the community versus always having to send patients elsewhere. From an emergency department, one of the biggest opportunities, and this is particular for our critical access hospitals. Now, critical access hospitals are required to provide 24/7 emergency care coverage with an emergency provider. Now, oftentimes when we go in and look at the cost report of these critical access hospitals, we see a significant opportunity around the ability to track the professional versus the standby time for those emergency room providers. And when we look as an average across, the average visit across the country should be 20 minutes of professional time per ER visit. Now, what happens is if we are higher than that 20-minute threshold, we are generally allocating too much time to the delivery of care and not enough time to the standby side. And every dollar that we reduce out of the standby time and put on the professional side is expenses and costs that is not going into that cost-based rate. Now, we've seen organizations that have been upwards of 90 minutes professional time per patient visit as an average. And I could say, at least from all the times I've been to the emergency room, I don't think I've ever met with an emergency room provider in 90 minutes in total, never mind seeing that as an average across all patients. Now, doing time studies is something that can lead to a material difference in reimbursements that you receive as an organization. Now, many organizations have started to leverage technology or other means as a way to track effectively the amount of professional time versus standby time. At a minimum, we need to ensure that we are doing the time studies to adequately track the amount of professional time versus standby time. But again, we want to look at all of those different factors to ensure that we are not over carving out money and putting ourselves in a bad position from that perspective. The last area around the emergency room is really the leveraging of KPIs. As we continue to move more towards quality improvement, performance improvement, outcomes driven results, we need to start to build all of these KPIs within the different departments of our organization. Now, again, this is not to say that every department should have 20 KPIs, key performance indicators, but every department should have some level of indicators that allow you to evaluate the performance for that department. Now, one thing I also want to emphasize too is many times we'll go into an organization and they will implement KPIs that are very much at that 50,000 foot view. And those are great to show the overall direction of an organization. The concern is that when we select KPIs that are at that 50,000 foot view, it makes it very difficult to evaluate whether or not we are improving relative to a given area. What I mean by that is that there are 1,000 different things that go into making up a KPI. If you are getting worse, you are going to spend a significant amount of time evaluating all of the different areas to find out which one is actually causing the issues relative to that KPI. So select some of those organizational KPIs that show general direction, but also select granular, very defined KPIs that allow you to get down into specific functional areas so that you can evaluate those different areas for improvement. And again, as you show improvement in those different KPIs, change to a different KPI. Don't keep the same KPI for 5 years. As soon as you show some improvement and hardwire the processes, go to another KPI and start to focus on that area. The next area we're going to focus on is quality improvement. Now, from a quality improvement perspective, again, very much KPI driven. What I want to emphasize from the quality improvement perspective is breaking down again the silos between clinical and finance. What we've seen from an organizational perspective is those organizations that have implemented a performance improvement executive committee, and again, that's the term we use and other organizations use. As long as the concepts are the same, you can really define it as whatever you want, but implement a performance improvement executive committee. And the goal of the Performance Improvement Executive Committee is to come together both on the clinical and finance, get rid of a solely functioning revenue cycle committee and a solely functioning quality improvement committee, bridge those together. The reason for that is one is realizing the linkages again between clinical outcomes and finance and breaking down those barriers. Realizing that clinical functions and outcomes has a direct impact on financial performance, and financial performance has a direct impact on what we can afford to do on the clinical side. We need to start coming together, our CNOs, our CFOs, and really working together to identify things that will improve the organization as a whole. Again, I've seen before a separate revenue cycle committee and a separate quality improvement committee where some of the actual KPIs of those committees, if one was successful, the other side would have had to fail. Or if the other side was successful, the other side would have had to fail. Again, you got to work on those linkages of bringing everybody together from that perspective. Again, so breaking down those barriers. Now, from a revenue cycle perspective, with revenue cycle, I would say this is one of the most overlooked areas within our organizations. And oftentimes people think that revenue cycle starts at the point that we code a claim. So coding a claim through collections. The revenue cycle process actually starts long before a patient ever shows up to your facility. The revenue cycle process actually starts when you're starting to negotiate your payer contracts. when you're establishing your IT systems, establishing your CDM, all of those different things are a part of the comprehensive revenue cycle process. And what we need to do is we need to take that into account when we're establishing processes to ensure that all of the different people that play a role in the revenue cycle process. And again, our providers are one of the biggest players in the revenue cycle process that dictates whether or not we will get reimbursed for services relative to documentation, services provided, all of those different factors. We need to engage them as a part of the revenue cycle process. What I would also like to say too is relative to revenue cycle, if we focus more of our efforts on the front end process instead of the back end process, we as an organization will continue to improve our metrics going forward. For example, if we don't get insurance cards from our patients, or we don't check addresses, or all of those different factors, it's hard to get a high score or a high percentage on first pass and clean claims ratios and all of those different things if we do not get all this information on the front end. So what we've seen is organizations that focus more on the front end processes and really expend the efforts there do exponentially better on achieving net days AR and lower DNFB numbers and all of those different factors going forward. Again, look at all of those different things from that perspective. The last thing around revenue cycle is really around your charge description master, your CDM. Now, from a CDM perspective, this is something we want to evaluate at least annually as a critical access hospital. The reason we want to evaluate it at least annually is because of the services that we're providing and the direct impact that your CDM has on the cost passed on to your Medicare beneficiaries. Now, as a critical access hospital, the coinsurance / deductible for a Medicare patient is 20% of the charges on that outpatient side. So what happens is that when we think of from a PPS hospital perspective, every single year, our large PPS hospitals will just, let's just say, increase charges every year 5%. That can end up putting us in a bad position as a critical access hospital because every year that we increase our charges greater than what our cost goes up, we just pass more and more cost onto the beneficiary in the way of that coinsurance. So again, evaluate your CDM and look at it from that perspective because we don't want to continue to pass on too much cost. I think last year when I looked at all of the cost reports for critical access hospitals across the country, I think there was something like 20 hospitals across the country. Their CDM was so high as a critical access hospital, they passed on 100% of the cost of care for their Medicare beneficiaries in the way of coinsurance and deductibles. And Medicare actually sent them no money for the services that they were providing. So again, evaluate this. A good way that you can check this is if you actually look at your worksheet E Part B, you can look at the coinsurance. It's on one of the lines, coinsurance and deductibles. Divide that into the total cost. If it's greater than 40%, this is generally something we flag to say that you should be evaluating your charges going forward. The next area is around cost report improvements. And I know every critical access hospital loves to look at their cost report. It's definitely an area where you can pick up reimbursement advantages or gains. When we look at our cost report, again, I'm not going to go into all of these nuances. It's going to be provided in the PDF. When we look at our cost report, what we really need to start to do is we need to merge the art and science of cost report preparation. The science of cost report preparation is making sure that you put the right numbers in the right boxes. Again, so put in the right number of SNF patients on the S31, making sure your expenses are tracked correctly and all of those factors. The art side of cost report preparation is really looking at how the numbers and factors go into dictating the reimbursements. An example of the art side would be the evaluation of your emergency department standby time that we were talking about earlier. And knowing that if the average is 20 minutes per ED visit across the country and you're at 40 minutes, is something being reported wrong? So again, it's not did you put the wrong number in the wrong box? It's are the numbers themselves accurate relative to your operations that then go into the boxes themselves. I would say this presents one large opportunity for organizations, particularly our critical access hospitals, to increase the reimbursements from that perspective. Now, the example up here on the screen right here is an organization that was at 38 minutes of professional time. And if they were able to get down to 20 minutes of professional time, it would have increased the allowable expense on their cost report. Just from Medicare, again, not even taking into account Medicare Advantage or Medicaid if you're a cost-based state, just from Medicare, getting down to that 20-minute benchmark would have improved or increased their reimbursements $156,000. Now, I know that organizations that leverage technology, they're able to get down to an average of 15 minutes. So again, you would have been able to add a fourth of that cost back onto your cost report. I don't think there's any critical access hospital across the country that wouldn't like to receive another couple $100,000 a year in reimbursements based on how the information is reported. The other picture up here also is looking at how we want to evaluate whether or not, again, that we're reporting those numbers correctly on the cost report. So when we talked earlier, we talked about the fact that the nursing facility has an impact on your reimbursements received. So this organization right here, they reported the days on the wrong line on their S31. And what that did is because they reported the days on the wrong line, it led to a dilution of their cost-based reimbursements. So in this situation, if they had recorded the numbers correctly in the right location, they would have received $76,000 more in reimbursements than they did receive by having those numbers on the wrong line. The reason why I'm highlighting a couple of these things is, again, just to show the perspective of the art side versus the science side, knowing the accuracy and the validity of the numbers themselves. The last couple areas we're going to focus on today, first being management accounting. The thing around management accounting, I would say, is, again, break down those silos. Get our department managers, our emergency room, our CMO, all of our people that provide the services, get them more actively involved in the budgeting process and managing the department P&L. Get them to have some measure of accountability to the financial performance of those departments. Now, if they've never done that before, there's going to be a whole level of education that needs to be provided, but nonetheless, start the process of doing those different things going forward. And then the last area that I'm going to talk about for a second is really, I know it says affiliation strategy, and I really don't like that term because it doesn't really work for everybody. What we need to do in today's environment is evaluate how we can start to collaborate regionally with all of the different providers. Again, whether we are an affiliated relationship, staunchly independent, whatever else it may be. As we continue to look at how technology is impacting the providing of healthcare services, we need to start to reach out and work with other organizations, again, in a way that's mutually beneficial for both organizations. But we need to start to work together to expand access to care and reduce the overall cost of the services that we're providing. Telehealth is definitely a way that we can expand these services and increase access to care. Again, when we look at from the perspective of the Rural Health Clinic program, I'll give you an example. Like last year, as a part of the 2022 physician fee schedule rules, they expanded the ability of RHCs to provide telehealth behavioral health services within a rural health clinic. This is a way that we can expand access and potentially partner with other entities or increase service utilization. But the point really is again, evaluate all the opportunities that present and afford you to continue to serve as a safety net provider for your community. Now, I know I've gone through a ton of different categories very, very fast. I'm going to pause. We have about 5 minutes left on this presentation, and I want to make sure that I afford the opportunity for any questions that you may have, and then also for any wrapping thoughts for Laura. So I'm going to pause. If you do have questions, please unmute yourself, or you can submit them in the chat box.
Hi, Jonathan, this is Laura. I'm not seeing anything come through in the chat just yet. So while folks are thinking, I just wanted to remind folks, our next call is scheduled for February 22nd at noon. And we'll be talking about revenue cycle management during that time. All right. Well, if you think of any questions after this call, please feel free to reach out to me. I'm happy to get in touch with Jonathan. We talk regular. And thank you for your time. After this call, we'll have the slides sent out along with the recording link. So thank you, Jonathan, for your time.
Thanks, everybody, and have a great day.